The lungs are essential for breathing, bringing oxygen in and removing carbon dioxide. They are protected by the pleurae, thin membranes that help them move smoothly within the chest. In this presentation, we will explore their structure and function in more detail. To do so, we'll start with a brief introduction. Then we'll tackle the external and internal configuration of the lungs. We will discuss the anatomy of the pleurae. Then the anatomical relations of these structures, their vascularization, innervation, and lymphatic drainage system. And finally, some key clinical notes and applications, and a conclusion to summarize all the key points. The lungs are paired, asymmetrical organs where gas exchange takes place, ensuring hematosis. They are located in the thoracic cavity and are surrounded by the pleurae. First, we will go over the external morphology or configuration of the lungs. Contained within each pleural cavity, the lungs occupy the lateral parts of the thoracic cavity, on either side of the mediastinum, to which they are connected by the pulmonary pedicles. The lung has a soft and elastic consistency. It expands during inspiration but spontaneously recoils. The lung is shiny and pink but becomes bluish-gray in older individuals due to the accumulation of pollutants. Its average weight in adults is 700 grams for the right lung and 600 grams for the left lung. The lung has the shape of a truncated cone with three surfaces: a lateral surface, an internal surface, and a diaphragmatic surface. Three borders: an anterior border, a posterior border, and an inferior border, and an apex. The lateral or costal surface is convex in both the vertical and horizontal directions and is molded to the inner surface of the thoracic wall. It is crossed by the path of the pulmonary fissures. The internal or mediastinal surface is flat in the vertical plane and concave in the antero-posterior direction. In its middle portion, it features the pulmonary hilum, which is a depression where the various components of the pulmonary pedicles expand. It extends inferiorly with the triangular ligament. The right pulmonary hilum is oval in shape and is approached by the right main pulmonary pedicle with its three regions. Posteriorly, the main bronchus. Anteriorly, the right pulmonary artery and the right superior pulmonary vein. And inferiorly, the right inferior pulmonary vein. The hilum of the left lung is higher and more central than the hilum of the right lung. And it has a racket-like shape. It is approached by the left main pulmonary pedicle with its three regions, anterior, posterior, and inferior, similar to the right side. The medial surface of the lung features a series of depressions corresponding to the imprint of the various mediastinal structures. On the right, the contours are marked by a deep depression caused by the heart's right atrium, vertical depressions formed by the superior vena cava, the brachiocephalic venous trunk, and the brachiocephalic arterial trunk, and a curved depression marked by the azygous vein and its arch. On the left, the impressions are more pronounced. A pre- and subhilar impression formed by the heart's left ventricle. A broad arch-shaped impression created by the thoracic aorta, surrounding the hilum. And superiorly and posteriorly, a vertical impression from the left subclavian artery. The diaphragmatic surface corresponds to the pulmonary base, concave in all directions, faces downward and forward. It is molded onto the convexity of the diaphragmatic dome. Moving on to the borders of the lung. The anterior border separates the costal and mediastinal surfaces anteriorly. The posterior border separates the costal and mediastinal surfaces posteriorly. The inferior border, also called the circumferential border, delineates the pulmonary base. It has two distinct portions: a lateral and posterior portion, separating the base from the costal surface, and a medial and anterior portion, separating the base from the mediastinal surface. The apex protrudes beyond the thoracic cavity and above the superior thoracic aperture, and its lower boundary is marked by the groove of the first rib. Let's tackle now the segmentation of each lung, starting with the right one. The right lung is divided into three lobes by two fissures. an upper lobe, a middle lobe, and a lower lobe. The two fissures are the oblique fissure, running obliquely downward and forward, separating the upper and middle lobes from the lower lobe, and the horizontal fissure, branching off anteriorly from the oblique fissure, separating the upper and middle lobes. Each lobe of the right lung is further subdivided into segments. The upper lobe subdivides into the apical segment, the dorsal segment, and the ventral segment. The middle lobe is the smallest and subdivides into two segments: the lateral segment and the medial segment. The lower lobe is the largest, pyramid-shaped with its base facing downward. It subdivides into 5 segments, grouped into 2 categories: a superior group, that consists of an apical segment or Fowler's segment, and an inferior group or basal pyramid, composed of a basomedial or paracardiac segment, a basoventral segment, a basolateral segment, and a basodorsal segment. Moving on to the segmentation of the left lung. The left lung is divided by the oblique fissure, which runs downward and forward, into 2 lobes: the upper lobe and the lower lobe. The segmentation of the left lung closely mirrors that of the right lung. The left upper lobe is homologous to the right upper and middle lobes. It is divided into 5 segments in 2 groups. The first group is the superior group or culmen, divided into 3 segments: an apical segment, a dorsal segment, and a ventral segment. The second group is the inferior group or lingula, divided into 2 segments: a superior segment and an inferior segment. On the other hand, the left lower lobe is roughly symmetrical to the right inferior lobe. It is also divided into 5 segments in 2 groups: a superior group, consisting of the apical segment or Fowler's segment, and an inferior group or basal pyramid, consisting of 4 segments: the basomedial segment, the basoventral segment, the basolateral segment, and the basodorsal segment. Another aspect of the anatomy of the lung is its internal configuration. The pulmonary parenchyma is segmented into progressively smaller elements, accompanied by bronchial, vascular, and neural divisions that also reduce in size. This entire structure forms a tree. Each segment of each lobe is divided into numerous elements, each of which constitutes a functional respiratory unit, called pulmonary lobules. The morphological or anatomical unit of the lung is the Miller lobule. It varies in size, measuring 10 to 25 millimeters. It is traversed by a bronchovascular axis at its apex, which consists of the lobular bronchus is a 15th-order bronchus, branching into terminal bronchioles and then respiratory bronchioles. The lobular arteries, measuring 0.5 to 1 millimeter, follow the bronchial axis, unlike the pulmonary veins and lymphatics. And the veins that are distributed at the periphery of the lobule, within the perilobular tissue, from where they drain toward the pulmonary hilum. The Miller lobules, numbering approximately 5,000 units, are surrounded by a septal envelope attached to the pleura. Each lobule consists of 3 to 5 acina units, which themselves subdivide into alveolar sacs and then into alveoli. The alveoli are enveloped by arteriovenous capillaries. In the second part of this video, we'll focus on the pleurae. Each pleura is a serous membrane surrounding each lung. It consists of 2 layers: the visceral pleura and the parietal pleura. These 2 layers continue into one another at the hilum of the lung, forming the pleural cavity. The visceral pleura is thin and transparent, covering the surface of the lung and the lobar fissures, whilst the parietal pleura lines the deep surface of the cavity containing the lung, to which it is attached by a cellular layer called the endothoracic fascia. It is divided into 3 segments: the costal segment, the medial segment, and the inferior segment. The costal pleura is in contact with the thoracic wall. The diaphragmatic pleura is tightly adherent to the diaphragm, and the mediastinal pleura extends sagittally from the posterior surface of the sternum anteriorly to the lateral vertebral gutters posteriorly. It lines the lateral surfaces of the mediastinum and can be subdivided into 3 levels: The superior level or suprapedicular extends from the posterior surface of the sternum to the lateral vertebral gutters. Middle level or pedicular reflects around the hilum to surround the two pulmonary pedicles. And the inferior level or subpedicular. The three segments of the parietal pleura continue without interruption into one another, forming four pleural recesses. An anterior costomediastinal recess. A posterior costomediastinal recess. A mediastinodiaphragmatic recess. And a costodiaphragmatic recess. Let's examine now the anatomical relations of the lungs and pleura. Starting with the inferior or diaphragmatic relations. Through the diaphragm, the inferior surface of the lung is in contact with, on the right, the superior surface of the liver. And on the left, from front to back, the left lobe of the liver, the fundus of the stomach, the left adrenal gland, the upper part of the left kidney, and the upper part of the spleen, more laterally. The medial surface of the lung is in contact with the various components of the mediastinum, which often leave an impression. On the right, it is in contact with the components of the anterior mediastinum, that are from bottom to top. The heart, via the right atrium. The superior vena cava. The brachiocephalic venous trunk. And the right phrenic nerve. The components of the middle mediastinum, above the hilum, with the trachea. The arch of the azygous vein. The right vagus nerve. And the components of the posterior mediastinum, with the esophagus. And the azygous vein. And the lateral vertebral sympathetic chain. On the left, the components of the anterior mediastinum, from bottom to top. The heart, via the left ventricle. The ascending aorta. The left phrenic nerve. It is also in relation with the components of the middle mediastinum, above the hilum, with the trachea, the aortic arch, and the left vagus nerve, and the components of the posterior mediastinum, with the esophagus, the descending thoracic aorta, the thoracic duct, and the lateral vertebral sympathetic chain. When it comes to its external or parietal relations, the costal surface of the lung, convex in both vertical and horizontal directions, is molded to the inner surface of the thoracic wall, to which the parietal layer of the pleura is attached. Let's discover now the anatomical relations of the apex. Anteriorly, it is in contact with the subclavian artery, the anterior scalene muscle, the phrenic nerve, and the vagus nerve, giving rise to the recurrent laryngeal nerve on the right side. Posteriorly, it is in relation with the neck of the first rib, the cervicothoracic ganglion, and the first intercostal pedicle. Laterally, it is in contact with the middle scalene muscle. Medially, it is in relation with, on the right, the brachiocephalic venous trunk, the esophagus, the trachea, and on the left, the common carotid artery, the left subclavian artery, the esophagus, and the thoracic duct. Moving on to the vascularization, innervation, and lymphatic drainage of the lungs and pleura. The arteries and veins form two systems. A functional system including the pulmonary artery trunk. It arises from the base of the right ventricle and divides into two branches, right and left, which enter the corresponding pulmonary hilum. And the pulmonary veins. These drain oxygenated blood from the lungs into the left atrium. There are 4 pulmonary veins, 2 right pulmonary veins, superior and inferior, and 2 left pulmonary veins, superior and inferior, and a nutritive system including bronchial arteries, providing nutrition and oxygenation to the bronchial tree and the lung, and bronchial veins. Lymphatic vessels form 2 systems, one superficial, pleural, and the other deep, following the bronchial tree and pulmonary vessels. These 2 systems only anastomose in the hilum region. Along their course, pulmonary nodes, located along the segmental bronchi, and bronchopulmonary nodes located in the hilum interpose. Each lung has 3 lymphatic territories. Upper pulmonary territories, where the anteromedial part of the right upper lobe drains into the superior tracheobronchial and right paratracheal nodes, and the upper part of the left upper lobe drains into the prevascular and superior tracheobronchial nodes on the left. The middle pulmonary territories, where these drain into the superior and inferior tracheobronchial nodes, and the lower pulmonary territory, that include the basal segments of the lower lobes. They drain into the inferior tracheobronchial and juxtaesophageal pulmonary nodes. And finally, concerning the innervation of the lungs and pleura, the nerves originate from the pulmonary plexus and consist of parasympathetic neurofibers from the vagus nerve that are bronchodilatory, and sympathetic neurofibers that are bronchoconstrictive. Together, these anatomic fibers regulate bronchial tone, airflow, and blood flow in the lungs. With this in mind, we'll move now to some clinical applications by shortly mentioning the lung cancer. Lung cancer is one of the most common cancers worldwide. It develops within the lung parenchyma, often near the bronchi, and can spread along lymphatic pathways to the hilum and mediastinum. Because of its proximity to major vessels and vital structures, early detection is crucial. If suspicious, a bronchial fibroscopy with biopsy confirms the diagnosis. Cancer may spread via lymph nodes to the hilum and mediastinum, making surgery difficult. A full workup includes chest X-ray and CT scan. Chest X-ray screens for abnormalities like opacities, pneumothorax, or pleural effusion, whilst the chest CT scan assesses tumor spread in lung tissue and lymph nodes or vessel involvement. To summarize, the lung is a respiratory organ that also plays an important role in the purification and protection of the body against the environment with which it maintains constant air contact. A thorough understanding of its anatomy has become essential in order to make the most of advancements in surgery and modern imaging.